Welcome to This Week in Hearing. Hello, I'm Bob Traynor, your host for this episode that presents a new evidence based approach for hearing screening of preschool and school children. Today, my guest absolutely needs no introduction, as Dr. Jay Hall is well known to all of us with his work in many areas of the profession, but especially in objective hearing assessment. Thanks for being with us today, Jay, here at This Week in Hearing.
My pleasure, Bob.
So, in the U.S., almost all newborn infants now undergo hearing screening at birth, and school children screening programs have been around almost since the inception of audiology. So, what's the rationale for preschool hearing screening?
Well, you're right, Bob. Newborn hearing screening is at least universal in the United States, many other countries as well. And the technology exists. Obviously, screening a newborn infant would be impossible using pure tone hearing screening. And as you point out, hearing screening with pure tones has been around literally for 100 years. It actually predates the beginning of audiology. Here in my office, I have a 1920s era Western Electric screening device, which was used for school screening. So, and I remember being a master's student in speech pathology at Northwestern in the early 70s, going out with a little bell tone audiometer. We all remember those little black bell tone, pure tone audiometer. So, yes, it's been around. But the problems with pure tone screening have been recognized for almost as long as it's been available. And for many years, we had no other alternatives. But the concept of screening newborns kind of raises the issue, well, could we use some of the techniques that we use for newborns also for screening older children, particularly those in the preschool years that are they're not quite ready for pure tone screening, at least not by a technician or someone who's not an audiologist.
So, well, that's for sure. And we use a lot of technicians in the areas for newborn hearing screening for sure. But what factors contribute to the increase in the prevalence of childhood hearing loss between the newborn period and school entry period?
Well, that's actually the motivation, the primary motivation for screening preschool hearing and preschool children, particularly the younger ones. So they've left the hospital and they're not yet in school, sometime between maybe 3 to 4 months after birth and when they enter kindergarten. The reason for screening those children, there are many reasons, but the primary reason is many more children enter school with hearing loss than were born with hearing loss. So let me just give you an example. If you took 100 children in kindergarten, all of whom had a hearing loss, had been diagnosed, and went back to their records, their medical records for when they were born, you'd find that only a smaller percentage actually had a hearing loss at that time. So most of the hearing loss in children by the time they enter school was not congenital. It was acquired at some point in the preschool years. So that's one main motivation for preschool screening. There are numerous Joint Committee on Infant Hearing has identified numerous risk factors for either delayed onset hearing loss, which means they start out with perfectly normal ears, but then they develop the hearing loss, or progressive hearing loss. So they may have actually had some subclinical degree of hearing loss when they were born, but over the preschool years, it progressed. So the prevalence of hearing loss at school age is about almost 10 times higher than the prevalence of hearing loss in infants. It's amazing. So you really can't assume that you're identifying all children with hearing loss just because you've got a very successful newborn hearing screening program. Now, there's one other factor I'll just add here, but that's the children who have acquired loss. But even in the United States, where you have universal newborn hearing screening, not all the children who fail the screening in the nursery end up getting the diagnostic testing they need. And there are multiple reasons for loss to follow up in that population. And then even a smaller percentage of the children who actually fail the screening at birth actually get to at the intervention stage. So in other words, some of the children they're diagnosed with hearing loss and then something happens and they never end up getting the intervention. So in some states, less than 50% of the children who fail a screening, who probably have some degree of hearing loss, actually get the intervention they need. This preschool hearing screening is one mechanism for finding those children who slip through the cracks and make sure that they don't go on with hearing loss throughout the preschool years.
Well, now, just so we say something about it, um, pure tone hearing screening of children is pretty commonplace in school audiology programs and that type of thing. Uh, just so we say so that what is a new screening approach and well, really why is it really needed? And I know that it's needed, and we all know it's needed. Well, let's just kind of go over why it's maybe needed in the children that are preschool age and school entry age.
Sure. That's a very good question. And there are multiple reasons why it's needed, why an objective approach is needed. Let me just talk a little bit about pure tone hearing screening, even though we all know it exists.
Yeah.
Let's kind of look at it.
We've all read it a couple of times, right? So
That's right. Now, there's no question when a child is in the second or third grade and older, pure tone hearing screening is a great option. They understand the instructions. It can be done pretty quickly, as long as you have a quiet environment, and the results are adequate. In other words, you can identify hearing loss that might influence school performance. But when you move into the preschool population or even kindergarten, I've screened thousands of kindergarten students myself. You have some kids that just can't understand the task. They may have a hearing loss, they may not, but they just can't be screened. And then and of course, this is by an audiologist. The literature clearly shows that non-audiologists, the people that actually do the screenings, whether it's in a school or a pediatrician's office, they struggle with pure tone screening, with understanding, getting the kid to understand the task and actually completing the screening in an adequate way. That's even in kindergarten kids. When you move down to age 4, 3, and younger, the statistics clearly show that the false failure rate is horrible. You're failing a lot of kids or just not able to screen them. So these kids are written off, which is a shame. Here you have a group of children, but because they're younger, people say, well, we could test them. We'll have to wait until they're older. There are alternatives. And the newborn hearing screening experience has kind of guided us to those alternatives. So we'll get to talk about it a little more in a moment. But bottom line is our research and the research that's been published recently shows if you combine distortion product OAE screening, and we'll talk about the technique in a moment, and tympanometry, you'll kick up all the kids in preschool era or age group with hearing loss. You'll do it quickly. Anybody can do the screening. They're pretty much automated techniques. And you won't have to deal with the many problems of pure tone screening.
so um so how do you go about doing this particular procedure on these preschool kids, Jay? Uh, and there could be colleagues out there that figured this out already and they're doing it. But well, what's your recommendation to how we go through with this with the preschool children?
Well, first I'll just comment on what you just said about colleagues out there doing it. I guarantee they are. There are people using pure tones and DPOEs and tympanometry, not pure tones, just because it works and it's quick and it's much more effective. And when I've done training of non-audiologists, just technicians or volunteers, when I've done training of them before they go into the schools to screen, when I give them all the training, here's how you do pure tone hearing screening, here's how you do DPOAs and tympanometry, they beg and plead me to allow them to use DPs and tympanometry on all the children. They really realize how simple it is compared to pure tones. So here's the approach. For DPOAEs, it's a little bit different than it is for newborn screening. For newborn screening, we just say, is there a DP there? Is it 6 dB above the noise floor, usually up in the 2 to 5,000 hertz region? If so, they pass. That's not adequate. That's not rigorous enough for a school screening. We want to match the sensitivity of pure tone screening. So we want to make sure the kid has no hearing loss. Not that they might have a 20 or 30 dB hearing loss, but it's not going to have a great impact on their speech and language acquisition. We're interested in identifying any hearing loss. So for DPOEs, very simple. Any DPOA screener, handheld device, just a little bigger than a cell phone, can easily be programmed by anyone to present 4 frequencies, 2000 hertz, 3000, 4000, or 5000. Present the tones, look at the DP, the machine analyzes DP, and it's got to meet true criteria. It's got to be at least 6, the DP amplitude's got to be 6 dB above the noise floor, just like for pure tone screening. But the second criteria is the DP's got to be at least a greater than 0 dB SPL. In other words, it's got to be a reasonably good DP. It can't be way down in the negative region. That will eliminate the possibility of passing a child who actually has a cochlear hearing loss. Now, the other component, tympanometry, which we're all familiar with, been around for over 50 years, that is very important because tympanometry identifies middle ear disorder. The most common reason a kid in preschool or even kindergarten fails a screening is not a permanent sensory hearing loss. The reason most children fail screening is a middle ear problem. So the tympanometry picks them up. If you have a child with normal tympanometry and a failed OAE screening, you can be quite sure there's a cochlear loss. If they fail both, it may be conductive, maybe sensory, more diagnostic testing would be needed. And if they're never going to fail the tympanometry and pass the OAE screening because they'll have middle ear problems. So in a matter of literally a minute to 2 minutes, you know pretty much who has a hearing loss, who doesn't, and even you know who to refer to. Middle ear problems, refer to the physician. Sensory problems, send them to an audiologist.
But isn't that a whole lot different than the old VRA techniques where it took us a couple operators to figure out whether to get one frequency sometimes? And, but,
Can I add something to that, Bob? Because I'm glad you brought that up, the VRA. If you look at the clinical practice guidelines for childhood hearing screening, the old ASHA guidelines from 1997, or even the more recent American Academy of Audiology guidelines for 2011, when they're talking about pure tone screening, immediately in the guidelines, they'll say, well, sometimes you're going to have to use conditioned play audiometry with these children. Well, gosh, I mean, you're not going to find some poor technician or volunteer in a school knowing anything. They don't even know what conditioned play audiometry is. So you're right. Those kinds of strategies have their place in diagnostic pediatric audiology, but not in hearing screening. It's got to be the physicians want something simple. It's got to be reliable. And it's got to be feasible. It's got to be something that actually can be done outside of an audiology setting.
So there are differences then in how we approach the DPs with this population we're talking about, preschools and in entry into school, than with the newborn hearing screening programs.
Yeah, there's a protocol, and I'll make sure that protocol is available to you so people can actually see the differences. And they'll recognize them right away.
Now, I assume that the advantage of using the tympanometry is to rule out the conductive element, because most of those kids will, I'd say the prevalence is extremely high in that group of having some sort of conductive, whether it be a very mild thing or whether it be something that creates big issues. So that's the rationale behind using the tympanometry with the DPs. And if it's a go on the tympanometry, then we move on into the DPs.
Yeah, it can be done either way, Bob, and that's exactly right. If you only use DPs, it's not a bad thing. It's still better than pure tone audiometry in preschool population. But when they don't pass the DPs, you don't know why. Whereas adding tympanometry, and we all know how quickly that can be done. And by the way, you can use the same probe size for a kindergarten or 4-year-old for both the DPOAEs and the tympanometry. So I've done this, as I said, in a matter of 2 minutes. I've done both on both ears. It's very, very quick. And so that adding the tympanometry and the research, and excellent research published in 2023 on thousands of children, show that just by adding that tympanometry component, you increase the sensitivity to any problem, even as you pointed out, maybe a little eustachian tube problem that's going to lead to otitis media, even refer that patient and maybe even prevent a hearing loss from happening. So the combination DPOAE plus tympanometry is much better than certainly either technique alone.
Now you mentioned one of the studies, but how much research is there out there on, because not only do we want to come up with a new process that's going to be more efficient and more effective than what we've been doing with pure tones, we need to have some sort of evidence to hand off to special ed directors and people that run this oversee school screening programs and those kinds of things, as well as to physicians and other colleagues that are responsible for these kids.
Right. Well, there are dozens of articles describing DPOAE hearing screening of preschool children versus pure tone audiometry. Um, and most of them have been done by audiologists, although there are some that have been done by other groups. Of course, there are many articles describing just pure tones, but this study I was referring to in 2023 is the first study of almost 1,500 children in Alaska, um, all ages from preschool up through early school age. And that's the first study that's statistically confirmed that pure tone screening just can't match up with a combination of DP and tympanometry. And so the next step, you mentioned school boards, but the next step is for audiologists and pediatricians and those who work in school systems to revise their clinical practice guidelines to include this new technique. Now, if only has a pure tone audiometer, that's the existing standard, so to speak, that could still be done. But as um, peop school officials and audiologists begin to look at better ways to screen preschool kids, these new techniques, DPOAEs plus tympanometry, really should be in the clinical practice guideline.
Well, schools are always concerned about costs, and they're always concerned about, oh, gee, this is going to add some expense and that kind of thing. But this equipment is not ridiculously expensive anymore, from what I remember. Was when we started to what it is now. And
Yeah, that's
so,
okay.
so and I'm sorry, Jay. Would you?
You nailed it. You've hit upon it. Critical, probably the biggest concern or objection that's going to be raised to say, well, we've already got the pure tone audiometer or screening device. We can't afford this other equipment. We had the same discussions and arguments, debates back in the early years of newborn hearing screening in the 1980s. And you have to look at the big picture. Say, okay, yeah, you have to buy an ABR system, or you have to, buy an OAE system. It's more than a pure tone audiometer. But let's look at the big picture. First of all, you're going to screen all the children. So you're not going to have, can you imagine a preschool kid who's in a school where preschool screening's done, but for whatever reason can't be screened, later found to have a hearing loss? Parents go to a lawyer and says, hey, I was promised my child would have their hearing screened so that they could be identified early. They've been going with 3 or 4 years with a hearing loss and nobody's done anything about it. So, I mean, I'm not suggesting the medical legal is the most critical. The bigger issue is there's a lot of wasted time and effort when you try to screen a child with pure tones. If they fail, but they shouldn't have failed, they're failing because they're immature, they didn't understand the instructions, or there's too much noise in the environment. There's concern on the part of the parents. They're going here and there for diagnostic testing. Wouldn't it be better just to find out one way or the other? And if, do they pass or do they fail? Do they have a hearing loss or not? The research, and there's some excellent pediatrics articles showing that if a child undergoes or if a bunch of children are screened with pure tones and they keep failing, they get to the pediatrician or they get to the audiologist and they have normal hearing, everybody starts to distrust the screening.
Yeah.
So you might as well not go through the whole effort. So yes, you got to buy the equipment, and of course in a school system it could be used in different schools. It could be shared. If you actually look at the cost per head of the child screening, I've done that for Head Start and preschool. It's minimal. It's around $30 ultimately. And there are groups, most schools can go to the Lions Club or Sertoma sometimes, that they're more than happy to say, yeah, you need a couple thousand for this newer device that'll do a better job. We'll provide you with money. So I don't think cost ultimately should be used as the determining factor.
Every time advancements happen in medical kinds of things, there's always costs initially. Now, indeed, many of the costs in the development of the emittance audiometry technique, as well as OAE techniques, many of those costs have already been absorbed by clinicians and clinics and hospitals, and now manufacturers have uh, more, say, reduced feature products that can be used for screening. So costs may not be quite as much as we think it is, and that would be for our school audiology people and maybe those that handle preschools to really do that. No, having been, and all of us have been at one time, most of us anyway, have been at one time responsible for a preschool child, and preschools are a petri dish for a lot of the things that go on in the auditory system. And we all know that from our own clinical experience, but probably as much or more from our personal experience with the raising the children ourselves. So, um, but with all of that said, is there going to be any residual role for the pure tone technique in working with these children, Jay?
Yes, I'm glad you mentioned that too. Yeah, I'm not saying throw away your pure tone hearing screening device, and or avoid it like the plague. There is a role, of course. And we know the cross-check principle, it always involves using multiple methods. So here's my protocol, and this is supported by the evidence, which is based on my experiences as well. Is in the preschool kids right up to age 5 and 6. So almost some kindergartners are 6 years old, but kindergarten, early first grade, just use DPOAEs and tympanometry. The research shows that's the best approach. But once the child gets, if they fail those two techniques, and if you have a pure tone screening and you have time, you can do pure tone screening just to get a rough idea. Now you've got three methods that might show a failure. That's going to compel everyone, pediatricians, parents. We got to do something about it. But the most important role for pure tone screening is in the children age 7 and older. So first or second grade and older. You can perform it in almost every child, but we know that hearing loss due to noise and music exposure, the prevalence is increasing in adolescents because they're listening to personal audio players. And so using pure tones and adding 6,000 hertz, that's a critical deviation from the normal protocol. So you use 1,000, 2,000, 4,000, and 6,000 hertz rather than stopping at 4. That will, in the older school-age children, start to pick up noise-induced or music-induced hearing loss. And the research that I referred to earlier, this huge study conducted in Alaska, showed that adding 6,000 hertz to the pure tone screening in kids 7 and older will lead to early detection of noise or music-induced hearing loss, which then allows you to prevent it. So yes, there's still a very clear role for pure tone hearing screening.
Well, and of course, we all, as audiologists and as we want to promote the profession, and of course, we would hope that the people that would be doing this would be school audiologists, would be audiologists that have contracts, say, with the preschool program, those kinds of things. But that said, now, um, what would you think about the pediatricians and family practice individuals that might use this kind of a technique to even find these kids maybe just even a little earlier or maybe a little more easily because they're having routine checks with their physicians over this period of time?
Well, that's a great point. Yeah, I mean, first of all, talking about the contract arrangements, and I've done that myself as an audiologist. An audiologist who makes a modest investment in an OAE and tympanometer, and they already have the pure tone screening, they can develop contracts with. I've done this with Head Start, with preschool programs, and actually generate revenue. Send a technician out to do the screening. Charge $5 or $10 per child for the initial screening and any follow-up that's needed, and actually make money. The pediatricians, though, you hit the nail on the head. That's the key difference. A pediatrician can, or their nurse or PA can, in their office, use tympanometry and DPOAEs very simply. They might even be able to bill for it because there are screening codes, but then we're catching the children at a very young age. They're almost always going to go to either a public health clinic or a pediatrician. And you mentioned the manufacturers earlier. The other benefit of that is now there's a whole new market for the screening equipment, which will probably end up driving the cost down over time. So pediatricians are ready to do it. They've shown interest. They're not going to do it with pure tone screening in the preschool population. But if they're approached with the data, they'll say, yeah, I want to help my children. I can do this at 6 months old, 1 year, 2 years, 3 years, and solve detect these problems in the pediatrician's office. They're ultimately in charge of the child's health. So they want to do it. It's just a question of, educating them about these techniques that are now feasible and available.
And I would think that we could add the family practice people to that as well, because many of those clinics have PAs and nurse practitioners and those assisting the physicians with their heavy loads usually. Well, since we've now described the problems with pure tone screening of this population and added now tympanometry and DPOAEs into the mix, how about a summary of kind of why and what we do?
Well, everything we do clinically should be evidence-based. It should be based on research findings. So I will admit that up till the last 5 years, maybe, there are plenty of anecdotal stories about how you didn't need pure tones. You could rely on either DPs or DPs plus tympanometry. But now the data is unequivocally clear. So in summary, I'd say we need clinical practice guidelines that reflect this modern evidence-based approach to pure tone screening that are produced by groups like the American Academy of Audiology or American Academy of Pediatrics. That's number one. Number two, we need to make sure that as audiologists that we're communicating with school systems and with pediatricians, with family practice people and saying, there's a different way of screening children, a newer, a better way other than pure tone screening. So we need to spread the gospel, so to speak. And people are slow to change. It's hard to initiate a whole new movement. We ran into that with newborn hearing screening. But ultimately, the evidence will lead us in the direction that we should go.
The only addition I might make to that, Jay, is if you are a private practitioner and you talk to your referral sources about this type of a new evidence-based screening approach, you look like the highest level people because you're the person that's telling them about something they don't know about.
You're differentiating your practice, Bob. We've talked about that before. No, exactly right. And this is my what they'll come to two conclusions. One is, hey, this person really knows what they're talking about. And the second is, if you convince them to do the screening, they're going to be sending you more children and more patients in general. So they are benefiting, the patient's benefiting, and of course your clinical practice is also benefiting.
Great. Well, I think that concludes. Well, we beat this horse a little bit hard today, but honestly, it's something that's absolutely necessary. And thanks so much for being with us today, Jay. And all of you out there, consider this evidence-based new method of hearing screening for preschool and school children. And thank you for being with us at This Week in Hearing.